It's already 2 o'clock. We'll start. First of all, I'd like to welcome everybody. Please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of companions attending with you so we can keep track of the number of attendees. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and end of the pep talk, so please show your face in the video during the picture taking. As a reminder also, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. I have placed the link in the chat box, and below is shown a copy of the picture of the certificate that I will be giving out. Again, as a reminder, having 50 OLETE certificates will entitle one to a voucher for free ROJoson telemedical consultation. Let's now have a group picture taking before we start the pep talk proper in 2 minutes. Please turn on your video. Please show your face. Okay. One. One. Ready? Everybody ready? Show your beautiful faces. 1, 2, 3. So let's start. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Goiter, Myths, and Tips. This is part of the health issue courses. The empowerment objective is for the lay people to have an understanding of all the the common issues involved in goiter. For some definition of terms, operational definitions of terms in the title, issues. I like to define issues as the mindsets and practices of people. When you say people, this will include not only the lay people, but also the health professionals in the community or in the Philippines regarding a certain topic that are open to question as to their validity or correctness or truthfulness and may be considered myth. When you say myth, these are widely held beliefs, but these are usually false beliefs and ideas. I use the word tips to mean advice from me. These issues, mindsets, and practices have created a lot of confusions among the lay people and health professionals in terms of health care and medical management, which has led to unwanted anxiety among the lay people and unnecessary and erroneous medical management by the health professionals. Because of this, there's a need for tips and advice. There are a lot of issues involved in goiter, especially in the Philippines, from the perspective of the lay people as well as from the health professionals. I will just tackle some, at least 5 issues, and give tips or advice. I've listed down the issues that I will discuss. Number 1 is concept of goiter. Number 2, bawal this, bawal that, foods in relation to goiter. Sa loob o sa labas na goiter. Interpretation of TSH, which stands for thyroid stimulating hormones. Low dose of suppressive therapy for colloid goiter. Later on, you can add some more. If you have some issues that you have identified, we will discuss this. Let's start with the concept of goiter. A lot of people, lay people, and healthcare professionals included, have the concept that goiter is a benign condition. When you say goiter, they thought it's always benign. This mindset have arisen from the encounter in the olden days when iodine deficiency or endemic goiter was very, very prevalent. Nowadays in the Philippines, iodine deficiency goiter is not common anymore. It's very rare. However, this mindset is a carryover of old mindset. So the tips here, a goiter is used nowadays to include any and all disorders of the thyroid gland, both benign and malignant conditions. So when you say goiter, it can be benign and malignant. It's not only benign. The most common presenting sign, at least the initial or the first cue for goiter, is the visible increase in the size of the thyroid gland. This is the most common. A lot of people and healthcare professionals just call the visible increase in size as enlargement without qualifying whether the enlargement is diffuse or nodular. Okay. So this 2 diagrams shows the concept of diffuse goiter. Okay. This is the normal thyroid gland. There are usually 2 main lobes, the right and the left. Okay. Then if the 2 lobes are almost symmetrically enlarged, okay, symmetrically enlarged, no, without nodules, okay, then we call that diffuse goiter. So this is an example of an diffuse enlargement of the thyroid gland. On this diagram, okay, this illustrates the concept of nodular goiter. If one lobe is markedly enlarged and the other one, so not symmetrically enlarged, in diffuse goiter, the 2 lobes are almost enlarged to the same size. That's why it's called symmetrical enlargement, almost. Okay, but here, if let's say if the right lobe is 2 times, 3 times bigger than the left lobe, then you label that as nodular goiter already. Okay. Another situation in which we can label the condition to be nodular goiters is that there are palpable masses, buccal, or lumps, nodules on these thyroid substance, either one or multiple. Okay, so these are 2 concepts of nodular goiter. This mindset of just calling the goiter as an enlargement has not facilitated the formulation of a clinical diagnosis, and it has led to non-specific diagnosis and shotgun approach in ordering diagnostic procedures. The diffuse enlargement or diffuse goiter has diagnostic implication different from nodular enlargement or nodular goiter. That's why it is very important to specify whether the enlargement is diffuse or the enlargement is nodular. If there is diffuse goiter, the connotation, the implication, the possibilities are hyperthyroidism or hypothyroidism. Okay, so these are called functional disorders. So if you have this diffuse goiter, you start thinking, is there functional disorders in terms of hyper or hypothyroidism? Now, in patients with nodular goiters, okay, the outright implication or the question to ask is that nodule, is that lump, is that mass, okay, benign or malignant? Okay, so these are, when you say tumors, no, it's classified under structural or anatomical disorders in contrast to the functional disorders. Okay, so for lump, it's whether it's benign or malignant. For diffuse goiter enlargement, is it hyperthyroid or hypothyroid? Okay, so the tip here is determine whether the goiter is diffuse or nodular, as this will facilitate formulation of a more specific diagnosis and avoid shotgun approach in the diagnostic procedures. So the second issue is bowel this, bowel that, foods in relation to goiter. Oftentimes, lay people ask whether eating cabbage, cauliflower, cassava, and other foods like soy, kelps are prohibited or bowel, as they can cause or aggravate an existing goiter. Oftentimes, health professionals answer the lay people yes, because they have not really read on the status of the issue. So there's a myth going on is that bawal ang cabbage, cauliflower, cassava, etc. for thyroid because they can cause or aggravate an existing goiter. So my tip is that they are not bawal. They are not absolutely bawal. The bottom line is everything is fine if taken in moderation, and foods will not cause goiter for the most part. Okay. Excess can cause hypothyroidism or hyperthyroidism. So a diet will not make your thyroid disorder go away, because there are some people who eat a lot of specific diet. Okay. So don't believe that it will make your thyroid disorder go away, except for the iodine deficiency goiter, and will not cause thyroid disorder. Okay. The third issue is sa loob o sa labas na goiter. Again, oftentimes lay people use these terms. Sa loob o sa labas pa itong goiter ko? I don't really know the origin of these terms as well as the exact meanings and significance. But I surmise or I guess, sa loob, when you say sa loob, or when lay people say sa loob, probably they are referring to hyperthyroidism when they feel symptoms and the thyroid is not very big, it's not prominent. Okay. Sa labas, a lot of lay people, I guess, are referring to the bulging masses visibly seen, readily seen on the neck and without symptoms. Okay. This is my guess. Okay. So the tips here, don't use these terms if there are no good basis and they don't have any effect in the medical management. In the medical world, we don't use these terms as the goiters grow in size within the neck. If there will be enlargement, if there will be growth, it will always start from the gland, so inside sa loob, okay? And then it will grow outwards, so palabas. Okay. So whether toxic or non-toxic goiter, it will start from growing in the thyroid gland itself, so sa loob, and then as it becomes bigger, the enlargement will be evident outwardly or externally. That's why it will grow because it grows outwards, okay, not inwards. The other issue is interpretation of the thyroid stimulating hormones, TSH. Okay. Oftentimes, nowadays, physicians, okay, this is the practice of the physicians. Physicians place greatest reliance on TSH to assess hyperthyroidism and hypothyroidism. The other tests used to determine whether a patient has hyperthyroidism and hypothyroidism are the T4 and the T3. Okay, these are the two thyroid hormones. Okay. Some experts have said TSH is the best and oftentimes the only test needed to assess hyperthyroidism and hypothyroidism. Okay. Because of this statement, a lot of doctors believe in this, so they will rely on TSH. Okay. My experience is that there is a lot of errors in the TSH determination. So my tip is always correlate the TSH results with the clinical picture of the patient before accepting the result. Okay. When you say correlate, check if the clinical picture, when you say clinical picture, how the patient is presenting in terms of signs and symptoms, okay, whether the clinical picture is compatible with the TSH results, whether it jives with the diagnosis of hyper or hypo. Okay, do not just accept the TSH results hook, line, and sinker without any reservation. I'll give you at least two examples. Case in point, number one, 25-year-old female diagnosed to have hyperthyroidism in 2019, okay, before the pandemic. So the basis for diagnosis for the hyperthyroidism, diffusely enlarged thyroid. There were no nodules even on ultrasound. So this is a first cue for possible hyperthyroidism or hypo. Okay. The pulse rate is fast, more than 100 per minute. So this is a cue for hyperthyroidism. With fine tremors on the hand, again, a cue for hyperthyroidism. And the thyroid function test, FT4, was high, and the TSH was low using the ELISA technique. Okay, there are two types of technique that are being used to determine the thyroid stimulating hormone, the ELISA and also the radioimmunoassay or RIA. Okay, so based on this diffuse enlargement, fast pulse rate, fine tremors, and then TSH low and high T4. Okay, so we accept the diagnosis of hyperthyroidism. Okay, so 99% sure that this is hyperthyroidism, and we accept the results of the TSH because it jive with the clinical picture. So patient was given PTU, propylthiouracil tablets, a drug for hyperthyroidism. She took this religiously, but the TSH has not changed. Okay, in low value, it has not increased despite 1 year of PTU. Okay, so September 2020, 2029 was the first diagnosis. Okay, after 1 year of treatment with PTU, the values were still the same. Okay, low TSH, it has not improved. So I decided to change the meds to methimazole, another type of anti-thyroid medication. So she took this religiously for 6 months, but with the serial determination of the TSH, there was still no change, no improvement. So the question is, what was happening? So no improvement in TSH for 1 year and a half despite the change in medication already. So I decided to request the RAI method for testing instead of the original TSH. And lo and behold, the values, the TSH is now normal. Okay. So this just shows or illustrates that there was an error in the initial TSH examination using ELISA technique. Another patient, 30-year-old female, diagnosed to have hyperthyroidism by a physician on the basis of just one TSH determination and value. So with a low normal value, the physician suspected hyperthyroidism, but just based on one determination. The other thyroid function tests, FT4, FT3, were normal. Okay? And there were no symptoms and signs of hyperthyroidism. Because of the mindset of the physician relying solely on the TSH, okay, with the TSH being low, ergo it should be hyperthyroidism, but the thyroid function tests were, the other thyroid function tests like T3 and T4 were normal. So there was no repeat examination to check whether the TSH determination was really accurate. So the physician prescribed, okay, and the patient took the anti-thyroid drugs for 1 year before consulting me. So I doubt the diagnosis of hyperthyroidism. So I said, just stop the medications and monitor yourself, and then repeat the TSH after 6 months, okay, without any medications. Okay. So after 6 months, the TSH and the FT4 values were normal. So just this case illustrates another error in the TSH. Okay. So condemning or consigning this patient to have thyroid disease, hyperthyroidism, if the error is not corrected. Okay. The last issue that I will discuss here is the low-dose suppressive therapy for colloid goiter. Oftentimes, physicians advise patients to undergo surgery for benign colloid adenomatous goiter, even if they are very small, still small, and or after no response to treatment with medications. Because one can try medications for benign colloid adenomatous goiter. Oftentimes, the dosage, if being given, is inadequate, and the monitoring of the duration of the response is not enough. Okay. This is a common pitfall by physicians. Okay. So a lot of patients with small benign colloid adenomatous goiters are being recommended for operation because of this issue. Okay. Now, the possible reasons for the pitfalls, okay, there is that mindset of the physicians that it is always dangerous to give high dosage of levothyroxine. Okay. So giving too high, it's true, there could be some side effects, but you can do it gradually and then observe. Okay. The other possible reason for the pitfall is the mindset that colloid adenomatous goiters usually do not respond to medical treatment. Okay, so it's true they don't. Majority will not completely disappear, but the medications can stabilize it, can avoid further increase in the nodules to the point that since you're not suspecting cancer, then you don't need to have an immediate operations. I usually give a high dose of suppressive therapy, of course, gradually, okay, in the form of levothyroxine for colloid adenomatous goiter for 6 months or longer. Okay. If there is response, then I gradually decrease the dosage. Okay. So with this approach, I've saved a lot of patients with colloid adenomatous goiters from unnecessary operations with my approach. So summary and takeaway. Okay. So I have discussed these issues, 5 issues on goiter, common issues, concept of goiter, okay, It's not always benign. It could be malignant. It could be benign. Okay. And the enlargement can either be diffuse or nodular. Okay. Bowel this and bowel that foods in relation to goiter. No bowel as long as you're eating them in moderation. Sa loob o sa labas, don't use these terms anymore. Okay. Interpretation of TSH, beware of the physicians relying too much on TSH without correlating with the clinical findings. Okay, picture. And then beware also of the low dose suppressive therapy being used by physicians, and then after no response, they would suggest operations. Beware of this. So takeaway in relation to patient empowerment, be always in touch with reliable medical information on issues on goiter. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in managing goiter. So with that, I end my pep talk. Goiter, myth, and tips. I hope I have empowered you to have a better understanding of the issues involved in goiter. Before we go to the question and answer portion, let me remind everybody, please take the OLETE for Mastery of Learning. Okay. The link is already in the chat box. And 50 OLETE certificates will entitle one to a free voucher for telemedical consultation. And with that, let's have a group picture taking before we start our question and answer sessions. Okay. Ready? Everybody, please show your face, unless you're sleeping. Okay. One more, Christy. Okay. No more? Christy, last chance, last call for Christy. One. Oh, okay. 1, 2, 3. Okay. So, okay, I'm glad we already have 19 participants. Okay. So, the floor is now open to questions and answers. Yeah, QA. Any comments, reactions? Who have experience being operated upon ready for MCAG among the participants in the group? Perla Pascua, yeah. Are you raising your hands? Perla? Okay. I remember your question last time, Perla.
Yes, doctor.
You went through the you had a thyroidectomy before?
Opo, total thyroidectomy.
For
Colloid adenomatous goiter.
goiter, yeah. Okay. How big was it before you were operated on?
Ay, hindi ko na maalala, doktor, pero dito sa gitna parang akyat baba siya, parang gaganong-ganon, parang sa lalaki ba na dito sa gitna siya tumubo eh.
Hindi, okay. Once sa gitna, talagang ganun, yung thyroid kasi nasa gitna. No?
Opo.
So kung may bukol na akyat baba, thyroid talaga yon, no? Okay.
Opo.
So my question is, how big was it? Halatang halata? Malaking malaki?
Hindi naman malaking-malaki,
Okay.
doktor. Maliit pa lang.
Okay.
Hindi naman
So,
siya
okay.
yung mga kagaya ng mga ganon, hindi eh.
Okay. Number 2, okay. Number 2, you were given medications first?
Marami akong napunta na doktor sa UST, sa Manila Doctors.
Binigyan ka ng
Binibigyan
gamot?
ng gamot.
Anong gamot binigay sa iyo? Levothyroxine?
Opo, parang
Okay.
hindi naman siya nawawala.
Okay.
Kaya sabi noon, pa-opera ko na lang daw.
Okay. Gaano katagal yung pag-inom mo ng gamot?
Parang years din po, doktor eh. Before
Years.
na nag-decide
Okay.
ako na magpa-opera eh.
Okay. Bakit ka nagpa-opera? Ayaw kasi
Kasi
mawala.
parang
Ayaw kasi mawala.
gusto kong mawala at saka ina-avoidan ko na maging baka pag matagal-tagal magiging ano siya yung malignant na sinasabi nila, baka mapabayaan, lumaki, baka
Okay.
maging malignant na siya, ganun. Kaya
Okay.
natakot ako, doktor.
Okay. So sino nagtakot? Did somebody tinakot ka ng doktor o ikaw
Hindi naman,
nagtakot?
yung mga kaopisina ko lang kasi nakikita nila kasi na ganun-ganun sa gitna ng leg ko eh. Eh, sabi
Okay.
nila, pa-opera mo na yan, parang ganun ba? Eh, nabuyo
Okay.
ako.
Salamat dito sa kwento mo. So it shows ang lecture ko, it shows that we have to correct all those myths, di ba? Kasi maraming naniniwalang ganito, and then na-influence kayo, no?
Oh,
Okay.
naku-confuse ako, natatakot.
So if you saw me during that time, probably hindi kita ooperahan, no? Okay? So butit na lang,
Parang
hindi nawala yung boses mo, butit na lang wala kang komplikasyon, no? Okay. Okay.
hindi pa kayo
So
kilala noon, doktor eh,
kaya nga,
kasi
hindi, okay lang.
that time kasi,
Sinasabi ko lang sa iyo yung dapat gawin,
opo,
no? Na you don't really need an operation, no? Yung what you have is yung tinatawag na MCAG, multiple colloid adenomatous goiter. Kung maliit,
goiter.
gamot lang, tuloy-tuloy lang, no? Okay?
Opo.
So kung
Oo nga, kasi
yung issue ng magiging cancer, 1% lang naman yan eh. Parang ano lang yan eh, no? Okay, bihirang-bihira. Don't worry about 1%, no? Okay? So, kasi I have a lot of patients the other day, sino ba yun? The other day, ganun din, no? 2 years bago siya nawala. Lumiliit naman siya. Okay? Kaya dapat babantayan. Even you have to have one doctor to monitor you. Kasi kung iba-ibang doktor, iba-iba yung pag-iisip nila eh. No? Maguguluhan ka lang. No? So the other day in my telemedical consultation, no? Okay, so it took us 2 years bago na lumiliit, no? Okay, okay, wala, hindi siya nag-attend today, okay. So 2 years ngayon lumiliit. There was a point na gusto na niya magpa-opera, sabi ko wag muna, okay. So ngayon masayang-masaya siya, no? Okay, no operation.
Oo nga, doktor, kasi noon, nung nagpa-check up ako sa doktor, parang hindi naman niya tinignan kung gagamot pa ako or parang i-opera ka agad. Kasi I was a member of the value card. Maalala ko, nagpunta ako sa isang secretary kasi yung doktor na nag-opera sa akin, hindi siya accredited sa aking card. Nung magpunta ako dun, sabi niya, parang kayo yun, sabi niya, bakit ayaw mo magpa-opera kay ano, ang galing-galing nga niya, sabi niya. Kaya parang na-realize ko ngayon, parang nagsisisi ako nung bakit ako nagpa-opera kaagad. Sana noon na opo.
Okay.
Kasi kung nakilala ko kayo sana noon, hindi siguro nga na-opera ako, doktor.
Okay, that's good. Okay, thank you for sharing your experience so that everybody would learn, no? Okay. And then it also validates what I was saying kanina, no? Okay, thank you.
Okay, doctor. Okay.
So,
thank you po.
Chuchi, you were raising your hands. Chuchi?
Yes.
Okay.
Wait. Yes. Can you hear me?
Yeah.
Okay. It's so funny because I came in late. I couldn't get the right channel. Anyway.
Okay.
So I was just so happy that I was able to join this particular because when you were describing everything, it's exactly what is happening to our driver. Remember, we have a driver who is exactly the same, who is in the same dilemma right now. Hindi niya malaman kung anong gagawin niya kasi he was advised by the doctor in Rizal Medical, kasi doon malapit sa amin eh, in Rizal Medical, that he should stop his medication Tapdin?
Tapdin.
Yes.
That's metimasol. Metimasol yun.
Yes. And then sabi ko, bakit mo na in-stop? Eh, yun ang sabi ng doktor. Eh, bakit yung isang doktor, kasi he had several doctors, kasi it's a public hospital. So
Yeah.
you cannot choose. Kung whoever is the doctor available, siya yung tinatanong. But they're all endocrinologists. Ha?
Yeah.
So, syempre, papaniwalaan naman itong si driver. Lahat
Okay.
ng sinasabi ng doktor. Pero I was already getting so confused with what the doctors were saying. No? So it's exactly the same as how you described it. He has been under medication for at least 1.5 years. Yung first, sabi raw kasi, we have to make sure that it reaches a certain level. Eh, hindi ma-reach yung level na yon until finally, nag-shoot yung TSH niya from something like 2 to 25.
2 to 25, mataas.
So, yeah,
Okay.
so
bumaliktad.
taas, sabi,
Bumaliktad.
That's very, very, hindi ka pala hyper. You are hypo. Ha? Oo, hinhypo na siya. I mean, they already gave the, parang verdict na, hypo ka na, stop the medication completely. So, in-stop niya. That was about, siguro mga 3 months ago. And then now, bumabalik yung mga symptoms niya, nagkaka-tremor, fast heartbeat, and he's so afraid na, sabi ko, magpa-test ka ulit ng TSH, baka naman iba na ngayon yung So I didn't know na meron palang dalawang techniques, ELISA and RIA, no?
Yeah.
So I'll ask him kung ano yung nakuha niya, kung anong technique yun.
Yeah.
And then,
yeah, you can ask him. Baka accurate naman yon. Yung kasi kung minsan hindi naman sinasabi natin yung ELISA is not she's not totally accurate, no? But you have to correlate it with the clinical picture, no? Okay.
yeah.
Nag-iiba lang yung values niya. Let's say RIA, usually ELISA kasi mura yon no? Mas mura yon.
I see.
Kung ELISA, no? Kung tama siya, and then there's a value already, and then as times goes by, na nagka-fluctuate yan, no? Even without medications, no? Okay? Or kung umiinom siya ng gamot, magka-fluctuate din siya. Bababa, tataas, bababa, tataas, gano'n, no? So importante, minomonitor lang siya, no? Minomonitor, no? So but somebody will have to know how to interpret it. Yung baba, taas, no? Okay.
Okay.
So yung sa kanya, kung kasi yung may tremors kamo, saka so we assume that meron siyang hyperthyroidism.
Hyper, yes.
So she was given methimazole. Okay lang yon, no? Okay. So that patient, your driver has to take it for a long time, no? Okay. Kahit sabi mo nga naka 1 year na siya, 1 year
Yes.
di ba? So
In-increase pa nila in-increase pa nila. So
okay. So kaya nga i-increase nila kung hindi pa makontrol yung hyperthyroid niya, na? Okay? So i-increase nila, pero pag na-increase na at naging normal na, they start bringing it, i-reduce naman, di ba? I-reduce naman hoping that you can get the hoping na baka totally mawala. Okay, that you don't have to take. Or otherwise, just baba lang, ma-maintain lang to a certain level. No? Okay? Kaya importante yung long-term, okay, as I said in my previous talk, na kahit na benign siya, hindi siya cancer, no? There are the goal is either some can be cured, some cannot be cured, no? Okay? Pero it's not life-threatening, no? You just have to be treated for a long time, and then you observe lang, no? Maano lang, inconvenient lang, no?
yes.
No?
And then tamang-tama yung sinabi niyo na yung sa loob or sa labas. He kept talking to me about, ma'am, yung sa loob daw. Ano pang sa loob? Hindi ko na maintindihan yung pinasabi mo na sa loob. Sa loob at sa labas. Anyway, nasa loob naman daw yung kanya, kaya hindi raw dangerous. Ganun ba? Sabi ko, sige, kung yun na sinabi ng doktor sa'yo. Pero now he's so confused. And so am I. Sabi ko, I'm also very confused with what's happening to you. So at least now,
Okay.
I can advise him again, no?
Yeah. Okay.
Very,
Okay.
thank you.
I hope yung sa loob sa labas did not originate from the doctors. I hope.
I
Okay.
hope so. And then he was saying, ang dami hong bawal sa akin. Sabi, we'll find out who told him that. Baka naman nakikita lang niya sa internet.
Yeah.
I will find out. And then I will tell him all these things that we took up today.
Yeah. Okay. Okay. So, okay.
Thank
The
you
other,
po.
okay. So, a related issues that we learned from your sharing is that, okay, when you're in the public hospital, no, talagang you don't have one doctor, no, iba-iba, no. So, and then we all know that if you have more doctors, no, chances are you also be confused, no. Ang daming mindset, di ba? Okay. So, as much as possible, as a rule, try to stick to one whom you trust, okay, or at most two, no. Wag maraming okay. Kasi yung sa public hospital, wala tayong magagawa kasi sa public, on duty sila every 3 days, hindi tuloy-tuloy, no? Okay. Unless may tinatawag na fellowship program, you can tuloy-tuloy yung assignment niya in one service, no? Ganon, no? But you have to look for him, no? Yan ang problema. Okay. So,
and then also, Doc, he's so afraid to have surgery dahil yun daw nakasabay, meron siyang nakasabay dun sa kanyang laboratory na wala ang boses. And so he's so afraid na baka raw mawalan din siya ng boses. Hindi ako magpapa-opera, sabi niya ganun. Maski anong mangyari dahil mawawala ko ang boses ko. Sabi.
Yeah, theoretically it's possible. Nasabi ko, operation of the thyroid. Buti na si Perla, hindi na wala ng boses. That's a risk that you have to take. No?
But there's a low probability, di ba? Hindi
Yeah,
naman.
yeah, but you cannot guarantee na no, it won't happen. No? It can happen to the best of surgeon. No? Okay. Kasi yung factors that contributing to the development to occurrence of hoarseness, number one is yung disease itself, whether it's nakadikit dun sa nerve, no, or not. Okay, kung malapit dun sa nerve, no. Number two is the surgeon factor, yung yung maingat na mabusisi, no. Okay, so two factors there, no. Okay. Kung yung let's say bukol nakadikit dun sa malapit sa nerve, wala kang magagawa, no? Kahit na magaling yung doktor, no? Okay? So that's what when I have such a situation, I always tell the patient na kung malaking chance baka matatamaan yung nerve mo kasi yung tumor, but and then I'll tell him that it's better to sacrifice the nerve than leave behind a cancer, di ba? Ganon. Yan ang kapalit, no? Okay. Pero kung benign lang, strictly speaking, dapat walang hoarseness. Okay? Okay. So, thank you for sharing, no? Okay. So,
thank you too. I appreciate it very much, you know.
Okay. So lumalabas na mga patient empowerment program natin, yung mga objectives natin, no? Okay. Okay. So any more sharing that you want to Belet, ikaw ba may thyroid, Belet? Kalimutan ko na.
Opo. I'm very thankful po kayo nakilala ko. Dahil dapat po i-operahin din niyo ako dito. Pero may nag-refer ho sa akin. Tapos nga, nagpa-check up po sa inyo ang inyong findings ay multiple colloid adenopathy goiter. Sabi niyo nga po ay hindi kailangan operahin. Tuminom po nung levothyroxine. Tapos sabi niya ang biling mura, yung Tidin. So yun ang po ginawa ko. Yun po ang aking tinake. Tapos after, hindi ko alam kung 6 months or 7 months, so ay nagpa-check up ulit ako, nagpa-ultrasound, lumiit siya.
Okay.
Tapos pinta niyo yung dosage po na 200 mg naging 150 na lang. So ito po ang aking iniinom ngayon. parang ang pakiramdam ko ay lumiliit pa din.
Okay.
Salamat. Ako kay
Okay.
Doctor.
Okay. There are how many of you now? Okay. 17. Okay. 17, can you help me in my advocacy? Number one, yung pangalan ng MCAG, bihirang gamitin yon. Probably ako lang gumagamit noon. Okay. So, because well, it has a basis historical wise. Okay, na yung pangalan na yon, even dun sa WHO listing, hindi masyadong ginagamit, no? But yung term na yon, I got it from a pathologist, no? When I was as a medical student, no? So yung pathologist ko, no, sinasabi niya multiple colloid adenomatous goiter, no? So to which I subscribe, maganda yung yung term na yon. It describes the nodules, no? When you say multiple, maraming nodules, di ba? Multiple, no? And then colloid, may liquid, may cystic, no? Okay, component. Yung solid adenoma yon, yung solid. Then goiter, no? Okay. So a lot of doctors are not familiar with those terms, no? With that, sasabihin nila, NTG, possible cancer, no? They're not very specific, no? So you can try to help me by telling your friends there's such thing as multiple colloid adenomatous goiter. It's very common, no? 99% probably among the women, no? Of that one, no? Kaya fortunately, maraming may multiple colloid adenomatous goiter na hindi naman kailangang operahan, no? Okay. So number 2, yung small chance lang magiging cancer yon, no? 1%. So don't worry about that, no? Okay? Huwag kang masyado mag-worry kasi 1% lang naman, di ba? Okay. And then pwedeng gamot. Yung gamutan matagal talaga, no? Okay? Okay. So number 1, yung iba, pag isa lang, colloid cyst, may isang, kasi multiple ito, no? Yung multiple MCAG. Kung minsan, they started with small one, no? Cyst lang, pwedeng mawala totally, no? Pero pag MCAG na, marami na, okay? 95% hindi siya mawawala totally. Okay? Hindi siya mawawala totally. But pwede siyang lumiit, no? Okay? So iinom lang ng gamot para huwag lang lalaki. Okay? So i-maintain lang, okay? Okay? So ganon, no? Kasi a lot of doctors, physicians, no, will tell you, hindi naman mawawala yan eh. No? Pa-opera ka na lang. Diba? Okay? So tama, kung magpapa-opera ka, mawawala. May kapalit. Diba? Magiging hypo ka rin. Pag naging hypo ka, total thyroidectomy, iinom ka pa rin ng thyroid hormones. Diba? Replacement. And then the other risky part doon, yung boses mo. Yung hypoparathyroidism, yan ang mga danger, no? Parang it's not worth it, no? Okay? Okay, for a benign condition which you can live with it for the rest of your life, no? Tapos magsasuffer ka lang ng hoarseness of voice, tapos hypocalcemia, hypoparathyroidism, no? Okay? So thank you for sharing. Sino pa bang may thyroid? Okay. Wala na? Who else would like to share? We still have 9 minutes to go. Lori, Alice, Aida. Aida, kilala na niyo si Aida. Maraming. Kay Aida, thyroid cancer. Pero okay lang siya. Papillary. Okay. So wala nang may thyroid. Phoebe, meron ka bang thyroid? Phoebe Hipos? Wala. Okay.
Ida had surgery.
Ha?
Ida have surgery.
Yeah, Ida has thyroid cancer. 33 years na siya. 33 years. Papillary carcinoma, no? And then with neck dissection, no? Okay.
But she's taking something for life.
Yeah, for
Yes po.
maintenance. Maintenance, no? Okay. Ayan si Ida. Okay.
At saka Doc, ang laking diferensya ng RIA sa Elisha.
Presyo.
Sa Medical City po, at saka plus FT4, nasa 3,000 plus eh. Pero
Okay.
pag sa iba, pag yung, mas mura lang po, 1,600 po, TSH, saka po yung FT.
Yeah, okay. Medical City, 3,000.
Apo. Last ko yung mga 2018, 2019, ang mahal nga po eh. Pero doon sa isa, yung Elisha, 1,600 lang po yung dalawa.
Okay.
Elisha.
Elisa. Yeah, Elisa.
Ah,
Elisa, basta Elisa, between Elisa and RIA, mas
ang laking
mura-
diferensya po sa Medical
malaking-
City.
Hindi, yung dalawa,
Kasi po nuclear siya.
nuclear yun, no? Kaya mahal talaga yung RIA, no?
Mahal ko yung
Okay.
RIA.
But you can start with Elisa, no?
Apo.
Elisa. Kasi ibang hospital kasi kanya-kanyang marketing yan eh. Sabi, mas accurate ito, ganun, no? Okay. So, but may kapalit, may price, no? Pero yung Elisa, pwede na, no? Pwede na muna kung compatible naman dun sa clinical picture ng hyperthyroidism, you can stick to that already. Kung may question as to its accuracy, then you can move on to the next, no? Okay. Okay, the same principle, parang yung principle na let's say kung meron kang problema sa lungs mo, magpa-chest x-ray ka muna, kung may nakita, baka pwede na, tapos na, no? Kaysa yung outright CT scan, no? Okay? Kasi yung current practice is kung may problema sa chest, unang kibot ngayon, CT scan na, di ba? Okay? So, ganun din sa RIA, saka ELISA. You can start with the cheaper ones. Kamisan, may 90% accuracy din yon, no? 90% is good enough, di ba? Okay? Basta ibabangga mo lang sa clinical picture, no? Okay? So kung if there is a need for more expensive another test, then you go for RIA, no? Parang yung kinuwento kayo sa kanina, no? Okay. So parang sa akin, okay. Before I go to that, RIA is definitely cheaper than more expensive than ELISA, okay? Pero yung, again, depende sa hospital. Kung Medical City is 3,000, Manila Doctors is 3,000. Nagulat nga rin ako sa 3,000 because during the pandemic, no? Pero if I go to another hospital, nearby hospital, pinagawa ko sa Medical Center Manila, the same RIA, 1,000 plus lang. So depende din sa hospital, no? Okay. So you have to choose, no? No.
Sa
So,
high precision po,
meron ba?
800. Sa high precision.
ELISA yon.
Kaya
Usually,
po,
hospital
pareho
lang
na silang 800. Kaya 1,200.
800 ELISA, di ba?
Apo.
Usually, yung mga hospital lang may RIA.
RIA.
Radioimmunoassay, no? Kasi that's part of the nuclear medicine department, no? So, kaya paminsan, nagko-compete sila, even within the hospital, magko-compete sila kasi business yan, di ba? So, ang gumagawa ng ELISA, yung laboratory in general sa hospital. May nuclear medicine, they do RIA, no? So, sasabihin nila, mag-RIA na lang kayo, dito na lang kayo. Okay. So, depende, no? So, any more? RIA. So if there are no more questions, Lana, last 4 minutes. So tandaan lang niyo, basta pag malaki ang leeg, kakapain, ha? Huwag lang titingnan, ha? Kasi kuminsan sa tingin lang malaki, baka taba lang 'yan, na? Okay? So kakapain, no? So kung makakapan yung thyroid, no? Then you have a goiter. Okay? Yan ang starting point, no? If you have a then titingnan mo kung diffuse yung dalawang lobes malaki or may bukol na isa, dalawa, tatlo, apat, no? Goiter pa rin 'yon, no? Goiter pa rin 'yon, no? Okay? So, yan ang starting point, no? Okay. So, wag na kayo matakot sa mga bawal-bawal na pagkain, no? Okay? Okay. So, just eat in moderation, no? Okay? Then yung iodine deficiency goiter, bihira naman yun eh. Wala nang problema yun, no? Okay. As I said, most of the time, if you mga babae ang merong MCAG, ang mga babae, kasalanan niya taksi ni Eva. Baka di ko. Okay, I don't talk about it. Okay. So, pero fortunately, benign din siya. Benign pa rin, no? Okay. So, if there are no more questions, we can call it a day. Then, next week, we will talk about skin and soft tissue tumors, no? Skin and soft tissue. I'll see, probably I'll limit it to 2 sessions lang, no? 2 sessions, no? Okay. Kasi broad din yung topic na yun, skin and soft tissue tumors, no? Okay. Okay. So,
Thank you, Doc.
let's call it a day. No more questions. Okay.
Thank you, Doc. Thank
Bye-bye.
Thank you po.
Bye-bye.
Thank you, Doc. Thank you. Thank you.
You're welcome.
Thank you, Doc.
Thank you, Doc.
Doc, thank you po.
Bye-bye. Bye-bye.
Bye-bye.
Bye-bye.
Bye po.
Bye. Phoebe. Bye-bye.
Bye-bye po.
Thank you po.
Ito yan, nakahabol si Irene.
Doc, late.
Okay. Chris, Alice. Irene. Okay. Okay. So, tuloy pa rin tayo? Tuloy, kaya pa ba? Tuloy pa tayo?
Nagsasalita pa, nag-live na ako.
Hindi kayo nag-live. Akala nyo na yung nag-live ka. Kasi hanggang Zoom.
Abet, ilan ang ano natin, participants?
Ay, hindi ko tayo
20, Doctor.
20. Okay. So, kanina nung 2 o'clock, kala ko baka 14 lang tayo.
Late lang pumapasok yung iba.
Okay. So, pag bumaba ang number, titigil na natin.
Paano yung study namin matitigil din?
Ha? Ano na?
Paano yung knowledge namin matitigil din?
Paano? Kung walang nag-attend, anyway, we'll see. We'll see.
Yung iba kasi umattend last Saturday, yung iba hindi. Pero the same number pa rin naman, Doctor.
Oo nga eh. Okay. Okay lang. Basta minimum 15. 15 to okay. Kung meron pa kayong ma-recruit, diba? Para
Yung mga nakikinig na lang, sinasama ko yung mga nakikinig lang din kasama sa house.
oo. Pero if you can, Phoebe, Belet, Irene, Lorly, if you can invite some more, para may motivation ako to, ituloy ang paghihirap ko.
Okay, Doc. Okay, Doc.
Okay, kasi kung kung kanina mga 12 lang, 5 to 9, di ba? 12 lang. Sabi ko, ay baka hindi na tumagal ito.
Ay, wag, Doc. Mas ganda. Na-empowered kami pag ganyan. Marami kaming nalalaman.
Okay.
Sorry,